Thank you very much for the invitation and the opportunity to be back to New York City after 3 years of virtual presentations. And thank you for the opportunity to talk about this topic. My disclosure. So lipedema has been a little considered disease for a very long time, often confused with lymphedema, phlebolymphedema, obesity, lipodystrophy, or chronic venous insufficiency. Because of its clinical presentation, the patients are often referred to venous specialists who are most often helpless, whereas lipedema is a worrying disease with a very significant impact on patients' quality of life, and with a prevalence which is probably not negligible. 10 to 20% of patients consulting lipedema centers would have lipedema, according to a recent consensus document on lipedema. Hopefully, things are changing with a growing awareness of this condition, which led the World Health Organization to include the lipedema in its international classification of disease, where it is described as a non-petic diffuse subcutaneous fatty swelling at legs, thighs, hips, and arms. So, because of this growing interest, we wanted to know the prevalence, the clinical presentation, and the surgical management of lipedema in our practice. We conducted a retrospective study reviewing all patients consulting for suspicion of chronic venous insufficiency during a decade. Among all patients for who the data were available, 86 were identified as having a pure lipedema, which represents 1.17%. And all of these patients were female. We wanted to compare this cohort of patients with the subgroup of female with edema but without lipedema, who have been seen in our center during the same period, in order to, because the clinical presentation could have been pretty similar. And this comparison has been very interesting. The patients, the female with lipedema, were younger, with a lower BMI, more frequently symptomatic, but less surgically treated. And when we focused on a group of the patients who have been surgically treated, all the 61 lips which have been treated are at C2 uncomplicated varicose vein stage, with an absence of saphenous reflux in 36.1%, and the surgical procedure consisting in 83.6% of the cases in phlebectomy with saphenous sparing, according to the Asval method. There was no significant immediate post-op complication, and the results at the control at 1 month and 1 year showed very good result for the symptoms, for the hemodynamics, and above all, for the patient satisfaction. So what we can say looking at this study is that when the lipedema is associated with chronic venous insufficiency, this chronic venous insufficiency was not at a very advanced stage, since 100% of the patients were at C2 uncomplicated varicose vein stage, with more than 1/3 without any saphenous reflux, treated by preservation of the saphenous vein more than 80% of the cases, whereas these patients were highly symptomatic despite this mild venous insufficiency. And we can also say that when the surgical treatment was needed, it was effective on symptoms, hemodynamics, with a very limited surgical risk. So there is a few messages to take from this study. The prevalence of lipedema in the population that consulted our surgical center dedicated to venous pathology was low. I'm talking about pure lipedema. Patients with lipedema were more often symptomatic despite a younger age, a lower BMI, and a less frequent venous insufficiency needing a surgical procedure. And finally, when associated with lipedema, venous insufficiency was at an early stage with simple and effective surgical management. Thank you for your attention.